Welcome to NSTS's Physiology Part 1 MRCS revision series. So there'll be another session on Thursday. For those of you who have been tuning in previously, we had 2 anatomy sessions last week. And again, the format of how we're going to deliver this teaching session will essentially be the same. We'll be going through what we believe have been high yield questions, or questions that have come up frequently in the exam by those who have sat it recently. The idea is less on emphasis of actually teaching the material, because hopefully you guys have been doing or are in the process of doing so, in learning obviously the theory behind everything. It's more going through example questions, going through the reasons why certain answers are asked, well, etc. So again, feel free to put any questions or concerns on the chat. We'll screen them, and we've got a poll to go through the questions, so try to engage in that, answer all the questions, and we'll get going. So I think most people have come in now, so we'll kick off with the first question. And there's the poll there. So a 26-year-old man presents with a laceration to his left arm. There is no neurovascular deficit, and the wound is cleaned and sutured. Which of the following cells are responsible for remodeling during wound healing? So there are the options there, A to E. And we'll give you about 15 to 20 seconds on this one. Okay, so just over half of you have voted so far. Give it a few more seconds. Okay, so we'll end the poll there for now. Thank you. So a bit of a split between B and E in the answers here. So about half of you went for myofibroblasts in B, and the other half went for fibroblasts. So wound healing is essentially, you can break it down into 4 stages. You've got obviously the coagulation stage, where any bleeding would stop, and you get vasoconstriction. And then you've got your inflammatory stage, your proliferation stage, and your remodeling phase. This is asking about remodeling. And each phase of those, and each cell type here in these options, are involved in different stages. And the answer to this question was B, myofibroblasts. So if we look here, obviously platelets and other coagulation clotting factors would be involved in hemostasis and the stopping of bleeding, making that fibrin clot. That would be obviously immediate. We're focusing on the remodeling stage, which can take up to a few weeks. Generally tends to start about 1.5 to about 2 weeks and onwards. And as you can see here, it's myofibroblasts that are involved in the main remodeling of cells. In the proliferative stage, you get both endothelial cells, vascular cells, and fibroblasts at that stage, causing the scarring. It's the myofibroblast that helps remodel. Okay. So we'll go on to the next question. And the next poll, thank you. So which of the following is not true about CSF? So those are the options there. And have a read through the options and see what you think, what's not true of CSF. Okay, about a third of you have voted so far. I'll give you about 15 more seconds on this one. I know the options are a bit wordy. Okay, so we'll stop it there. Pretty much everyone voted on that one, which is good. So a bit of a varied response. About a third of you went for C, and another third of you went for D. And then the rest of were split between the other options. So this, again, we're focusing on what isn't true. So essentially for these type of questions, again, you're going to have to go through the options and think through your head and eliminate options as you go ahead. So we will do the same here. Now, the answer in this question is C. CSF enters the subarachnoid space through two lateral foramina of Magendie and the central foramina of Lutschka. Okay. Now, first and foremost, I'll explain why that is the answer for this one and why it's not true. Well, the CSF, although it does go through both those foramina, it's the foramina of Lutschka, which are the lateral two foramina, and Magendie is the central one. And I remember that because Lutschka, L for lateral. So Lutschka is the two lateral foramina and Magendie the central. So if you knew that, you would know that C is definitely not true, which means it is the answer for this question. And then again, if you were confident on that, you could go through A, B, D, and E just to see. And yeah, CSF is produced roughly around 20 mils an hour. Total volume is around 150 mils in a typical 70 kilogram man. And so in terms of D, it's definitely recycled more than once a day if it's being produced at around 20 mils per hour. It's recycled roughly maybe up to 3 times or over 3 times a day. CSF is definitely produced primarily by the choroid plexus. It also passes into the fourth ventricle via aqueduct of Sylvius, so A and B are correct. And then E, majority of CSF is absorbed by arachnoid villi. That is the main mode of absorption. Okay, and majority is through the arachnoid villi into the superior sagittal sinus. Okay, and again, this is just a schematic showing the flow of CSF. Comes up quite a lot, if not in the physiology section, it will come in, neurocritical care or neurosurgery topics. So flowing from the lateral ventricles via foramina of Monro into the third ventricle, passes through aqueduct of Sylvius into the fourth ventricle, and then that's where it goes through one central Magendie and 2 lateral foramina of Lutschka. Okay, so we'll go on to the next question now. Brilliant. Okay, so a 56-year-old man is involved in a road traffic accident. They present with reduced GCS and head trauma. He's admitted to intensive care following intubation and stabilization. Which of the following is correct? Okay. About a quarter of you voted, so I'll give you a little bit more time on this one. Okay, just over more than half of you have voted. we'll give it 15 more seconds. Okay, we'll end it there for now. Okay, great. So real mixed bag in responses here. So 20% of you who voted went for A, autoregulation of CES, cerebral blood flow, occurs at 75 to 150. It's a bit of a tricky one. And we'll just go through them, but the answer here is D. Rate of production is 500 mils per day. Now, clearly in the question that previously, I said that CSF is produced at around 20 mils an hour. Now, if you have that over 24 hours, that's roughly 480 mils. And that's around the same ballpark as a 500 mils a day. Now, obviously, if you want to, those aren't absolute numbers in everyone, okay? And again, because of that, it makes this question a little bit tricky because you may not be entirely sure whether that statement in D will be taken as correct in the exam format. But in textbooks, over a day, 500 mils, per hour, 20, okay? Now, let's go through some of the other options as to why they aren't correct, okay? Autoregulation, it happens between 50 to 150 rather than 75. Now, obviously 75 systolic blood pressure, don't know how many of you guys have looked after very sick patients, but a systolic of 75 is very low, but have been seen in patients who are acutely unwell with, for example, sepsis or hemorrhage, etc. It's still a little bit too high for the lower figure for CSF not to cerebral blood flow not to auto-regulate itself. So it's 50 to 150. Okay. In terms of B, cerebral perfusion pressure rises. So as that rises, central venous resistance decreases. Now, if you think of cerebral perfusion pressure in the brain, now, in terms of the vasculature, if you have vasodilation, you have an increase in cerebral perfusion pressure, okay? And because more blood flow will go through. Now, if you have increased pressure, the body will try to essentially go against that. And so as a coping mechanism, the brain will likely try to vasoconstrict to lower that cerebral perfusion pressure. Hence, as the pressure goes up, venous resistance will also increase to try to vasoconstrict and prevent further increase in cerebral perfusion pressure, which is also linked to intracranial pressures. Okay, so I hope that makes sense. So although cerebral perfusion pressure going up is probably because of vasodilated vessels, which means central venous resistance is low, actually what you need to think about is what the body does to try to counteract cerebral pressure rising. So that's why if a question like this asks if as cerebral perfusion pressure goes up, central venous resistance will also go up as a coping mechanism, okay? Now, I hope most of you know that carbon dioxide is more of a potent chemical change in terms effect in cerebral perfusion pressures rather than oxygen, okay? So that's why C is incorrect. And Cushing's response, this will come up in a lot of your question bank, but essentially, rather than raised respiratory rate, bradycardia, and hypertension, it is irregular low respiratory rate, bradycardia, and hypertension, okay? So you don't get a fast respiratory rate in Cushing's response. So it's a bit of a hefty explanation to that question, but neurocritical care type questions will also often come up, if not within their specialty type questions, it'll come up in physiology. So there were a few things in the questions chat, sorry, so I'll just have a quick look. Okay, great. Okay, so sorry, yeah, making it clear, I guess what somebody put in the chat was autoregulation of cerebral flow occurs at 75 to 150. Technically, that is correct in terms of because the range is 50 to 150, it will happen. But in the purpose of exams, when they have these types of questions, they want, in terms of the range, that they will always ask for the absolute value of ranges rather than that it can happen within those ranges. Okay, so apologies in the wording of the answer in that option, but essentially if you're faced with an option in the exam where a range fits because it has to be correct, they're more often pointing at what's the absolute range that they want as a textbook answer. So we'll go on to the next question now. Which of the following is the site of action of antidiuretic hormone? Okay, just over half of you have answered this. So I'll give it about 10 seconds. Okay, we'll stop it there. Great. So vast majority of you have gone for E, the proximal collecting duct, and that is the correct answer. Okay, so ADH, which is obviously secreted by the pituitary gland, it acts on the collecting tubules, and it's the proximal part of the collecting duct that it does. So the collecting duct obviously helps aid, although it's not the majority, it aids in sodium reabsorption and also water reabsorption, and that's controlled and under the influence of ADH. Okay, and where different types of hormones act and also where different minerals or electrolytes are absorbed is something that you should take the time to understand and then learn for the exam, because it does come up quite frequently. Now, this schematic only shows the hormones that are affecting the collecting ducts. And as you can see, ADH is more in the proximal collecting duct, okay? But yeah, know where the majority of sodium is reabsorbed, where parathyroid hormone acts, etc., because those are common themes that they may ask, okay? So moving on to the next question. Right, which of the following statement is true regarding hemostasis? I'll give you a bit of time again for this one. Okay, so answers are trickling in now, so give it a little bit more time. About half of you have voted now. Okay, we'll give it 10 more seconds. Okay, so we'll stop it there. Right, so just over more than half of you who voted went for E. Heparin acts on the clotting factors 2, 7, 9, and 10. Now, the correct answer in this one is C. It's the thrombin time measures hemostatic activity of the common pathway. Okay, and we'll go through the different answers here, but it'll be useful to just go back and remind ourselves of the areas of that are tested here. Now, you've got the extrinsic factor, pathway, sorry, and then the intrinsic pathway, all right? And essentially, I'm sure you were all aware of studying for this in kind of med school finals and all of these things. I don't think it's absolutely necessarily to know and learn every single step of the way for this exam, but it's worth noting how each pathway is measured. Okay, then at least a cofactor, so factor 8, and how that coincides with, for example, von Willebrand factor, and knowing the common pathway is quite important. So it's not necessarily, going to be high yield to learn that. For example, you have factor 12 and factor 11, then factor 9, for example, etc., etc. If you do, that's great, but it's not necessarily absolutely necessary, I don't think. But going back to this, APTT measures the hemostatic activity of the extrinsic pathway. And obviously from this diagram, we know that the extrinsic pathway, which includes the tissue factor and factor 7 primarily, is the extrinsic pathway. So that can't be true. Okay. Prothrombin time measures hemostatic activity of the intrinsic pathway, and again is incorrect because it's, as I've just said, APTT measures the intrinsic pathway and it's prothrombin measures the extrinsic pathway. So those are inverse of each other and should be the other way around. C, the thrombin time will be the one that measures the common pathway, which is post essentially factor 10 and downstream from that. And that's how we measure thrombin time. If you just remember that essentially the common pathway starts with factor 10A complex that forms thrombin, you'll get thrombin time, okay? So that's correct. Now, looking at D, bleeding time measures the hemostatic activity of the platelet phase, okay? Bleeding time isn't measured just for the platelet phase. It's essentially the whole. Although you can use bleeding time as a measure of platelet function, it doesn't just measure when platelets are active. So strictly speaking, it's more the wording of how this is written as to why it's not a correct answer. Okay, so bleeding time is literally when you measure the time. You can give a prick to skin and you measure the time that it takes to stop, and there'll be a standard deviations of the average times it should take compared to the normal average person, and whether that's off or not. And clearly that will include platelet function, but it's not only the platelet phase, which is immediate. Okay. And E, heparin acts on clotting factors 2, 7, 9, and 10. So 2, 7, 9, and 10 is more related to warfarin, and it's those vitamin K dependent clotting factors that are involved and that are listed here. But actually heparin, depending on whether it's low molecular weight heparin or unfractionated heparin, it acts mainly on factor 10, but it doesn't affect all of these 4 factors, and those are more of a key one for warfarin. Okay, so C is definitely the correct answer in this question. Okay, so hemostasis can be quite tricky, but like I said, make sure you know what the intrinsic pathway and how that's measured is, the extrinsic pathway, how that's measured, the common pathway, and then, then drilling yourselves on the physiology questions that kind of come up on the pathway will be useful. Often they may ask questions about activated proteins C and S, so that can come up again as well. But from my experience, I personally didn't have any questions about individual factors. It was more about what measured what within the hemostatic pathway, or whether it was to do with heparin or warfarin affecting which factors. Okay, so we'll go on to the next question now. A 49-year-old male has been started on a PPI to control his symptoms of reflux. Which of the following is true regarding the physiology of the gastric acid pump? Okay, let's give you a bit of time for this one. Okay. So about half of you have voted. I'll give you a bit more time. Okay, let's give it 10 more seconds. Okay, let's end it there. So got a bit of a split between B and D for this question. So B, gastric acid is produced by G cells in the antrum of the stomach, and then a portion of you went for D, with the proton pump being the final pathway of histamine and anticholine stimulate acid production. So those of you who went for D, that is the correct answer for this question. Okay, so knowing the physiology of the stomach and the small intestines, and then the hormones that are involved will come up. It came up twice actually in my exam. Okay, so just going through the answers here. Let's go them systematically. But starting with D, if you remember that the proton pump here is the parietal cell. Okay, so it's the parietal cells that produce acid, and hormones that have a positive feedback mechanism locally in terms of its chemical effect are acetylcholine, histamine, and gastrin. Okay, so histamine and acetylcholine will both stimulate acid production. So if you can remember that, and there's I'll cover this a little bit later on again in a different example, but knowing the stimulating factors for acid production in the stomach is important for this exam. And then obviously you can also look at inhibitory factors as well. But in terms of the local chemical factors, acetylcholine, histamine, and gastrin. Okay. So for that reason, we know D is correct. Now in E, hydrogen ion secretion occurs by diffusion down a concentration gradient. We know that's not true because essentially it's ATP dependent. It needs energy, and it being an energy dependent pump, it can't be via diffusion. Okay, so that can't be correct. Looking at B and C, again, gastric acid secretion is stimulated by high hydrogen ion concentration. Isn't true, because we know that the actual stimulating factors, acetylcholine, histamine, gastrin, I'll go through some a bit later on, but the actual concentration of hydrogen ions, which is an end product, wouldn't be a stimulating factor. It would actually be the opposite. It'd be an inhibitory factor, because if you have increasing gastric acid levels in the stomach, it would have a negative inhibitory factor on gastric acid secretion. Sorry. Again, we've just seen from the diagram, it's parietal cells that produce gastric acid, not G cells, okay? That can be a little bit misleading, just because I know a lot of these cells, D cells, I cells, G cells, can be a bit of a misnomer with gastric acid. Gastrin is the hormone produced by G cells, okay? And then a proton pump is exchanged with phosphate ions. From this diagram, we know that that's not true, okay, because it's exchanged for potassium ions, okay? So we will move on to the next question. Which of the following statements regarding the renin-angiotensin system is not true? Okay, give you a bit of time. Just think through the different options. A third of you have answered for this one so far. Give you about 15 more seconds. Okay. All right, so let's end it there for now. Okay, so majority of those, of those that voted went for C, which is the correct answer. So here, low perfusion pressure is the sole stimulus for renin release from the justoglomerular cells. Okay, now that can't be true, because it's renin from the justoglomerular cells. It is produced, yes, from renal perfusion, so that's the perfusion pressure, but it also is stimulated from sodium levels, and it's detected in there, and then also from the sympathetic nervous system can also stimulate renin release. Okay, so it's actually it's untrue that low perfusion pressure is the sole stimulus. Okay, and most of you got that, which is really good. Looking at some of the other options, obviously, by definition, because we've gone through the one that's not true, everything else is correct. Angiotensin 2 is a powerful vasoconstrictor. Renin, we know, will cleave angiotensin 1 from angiotensinogen. Was the ACE, that enzyme that we often, ACE inhibitors, give people. It is mainly in the pulmonary and vascular endothelium. And then aldosterone, obviously, causes salt and water retention, and that's why we'll give aldosterone inhibitors, for example, to reduce blood pressure. And this is the schematic. And I think for whatever reason, it was a pathway that was a lot easier to retain when it came to revision for me. Obviously, everyone's different, but remember the key steps, remember the enzymes involved, and then remember the products and their actual function. So although angiotensin 1 leads to angiotensin 2, and then the end product kind of within this pathway being aldosterone, and that its function, know what angiotensin 2 does, which is its role as a vasoconstrictor too. So know, all of those things. But yeah, familiarize yourself with this. Again, quite a high yield topic in the exam. So moving on to the next one. An 85-year-old patient previously underwent a vagotomy procedure for peptic ulcer disease. Which of the following is incorrect regarding the physiological effects of a vagotomy? Bit of a tricky one, so I'll give you a bit more time for this. I'll give you 20 more seconds. About half of you have voted now. Okay, so let's end there. Great, thank you. So very split spread of answers, mostly between A and E, and a few going for B and C too. The answer to this one is E. It's vagotomy aids pancreatic exocrine function. Now, vagotomy is really not done anymore. Really, it's more of a historical procedure, especially for peptic ulcer disease, mostly because of non-operative options, essentially, that can have a huge effect. So, for example, H. pylori causing peptic ulcer disease, you've got eradication therapy that's successful now. You've got PPIs, which have a very good effect as well for this type of thing. And vagotomy, which is very invasive as it's a procedure, as well as the fact that you will get, various side effects from it too. It's not something we see often, so it's quite difficult. But essentially what you're doing is stopping the vagus nerve and the parasympathetic nervous system from innervating that general area to lead to reduced acid secretion. Because remember, rest and relaxation, digesting within that phase of that parasympathetic drive. And part of that is the parasympathetic nerve from the vagus that can, again, that's a positive factor in in parietal cells producing acid. Okay. Now, if you think about the vagus nerve, in effect, that helps parasympathetic drive, which helps rest and digestion. Pancreatic exocrine function is going to be active within that phase. So it's going to be something that's going to be positively affected by the vagus nerve. When you're digesting, you need to release all of these exocrine enzymes into your gut. And so if you do a vagotomy to reduce the vagus nerve stimulating, it's not going to aid exocrine function, it's going to reduce it. So E is incorrect. Okay. And that's what, and if we go through the others, obviously vagotomy reduces acid secretion by decreased stimulation of oxyntic cells. Oxyntic cells is just another word for parietal cells, but also, like I just said, it would, it's not, it's true because we cut the vagus nerve in the part that it affects that, and so you would get decreased stimulation of parietal cells or oxyntic cells. Vagotomy reduces gastric acid secretion in B by reducing mucosal histamine and gastrin release. Well, again, that's true because all of these hormones that are pro or positively affecting gastric acid secretion, like we saw in that diagram, which histamine and gastrin were, that is partly also driven by the vagus nerve. So it's this is going to be true because reduced vagus stimulation reduces these hormones. Okay. And again, in C, a bit of a tricky one because, this is something which probably I wouldn't have known either at the time of doing the exam, but reduced coordination of the myenteric plexus may lead to delayed emptying and gastric stasis. When you get reduced coordination, which you do, because you've cut the vagus, it doesn't just lead to delayed emptying and gastric stasis. You can go the other way too. So you can get hyperactive emptying when you get a vagotomy because you hold on to less in the stomach, and also you get essentially uncoordinated peristalsis as well from the myenteric plexus, which can give hyperactive emptying. And then again, going through D, post vagotomy, the pylorus fails to relax prior to the peristaltic emptying wave. It's true because you wouldn't get that coordination, like essentially for the justification for C, when the vagus is cut. The process by which parasympathetic nervous system drives rest and digestion is going to be uncoordinated because now you're going to have the guts nervous system, which is kind of your myenteric plexus, that's going to increase peristaltic activity, but also the pylorus. If a pylotomy hasn't been done and it's just a vagotomy, it may not relax in tandem. But again, for this type of question, I think if you just think simple and see what do you know, because, and that's how I sometimes approach these quite difficult questions. I wouldn't have necessarily known the fact that C and D were true or false, but I definitely knew that vagus nerve positively affects exocrine function. So this essentially, if you get rid of the vagus nerve, it can't aid it. It has to be the opposite. And so E is the correct answer here. And again, what we were talking about earlier, just to quickly add in terms of acid secretion, you've got 3 phases. You've got this cephalic phase and the brain stimulation from taste, smell, and the hypothalamus. And that's where the vagus nerve comes in to promote acid secretion. And then local effects in the gastric and intestinal phase. Okay, so we'll go on to the next question. Which of the following cells are responsible for producing somatostatin? Okay, give it 10 more seconds for this one. Okay, we'll stop it there. So most of you went for C, D cells, which is correct. It's one of those things really, although you could take an educated guess, it's one of those things where you know it or you don't. And it's important to, it's really important to know this. I think this exact question came up in my exam, almost word for word, just literally a statement, what cell produces what, or what hormone is produced by what cell. So some of the examples here I've given, so parietal cells we know as gastric acid, chief cells for pepsinogen, but otherwise D cells is for somatostatin, and that somatostatin, remember, inhibits acid secretion. So that's one of the negative feedback hormones for acid secretion. And G cells, like we talked about, is gastrin. Okay. And then yes, no, obviously what produces cholecystokinin, all of the other exocrine functions and those that are produced. So we'll go on to the next question now. Okay, so which of the following is correct regarding physiology of fluid balance? Okay, we'll give it 10 more seconds on that one. Okay, we'll end it there. Okay, so the answer that's correct for this question is D. So when you give a liter of 5% dextrose, the plasma volume only increases minimally, not a lot at all, and it's around 8%, of which 5% dextrose is absorbed. Retained in the intravascular space, which is part of the plasma volume. So when we look, I'll show you this diagram first of all. So again, just typically, I believe still for the exam, they will use your standard male 70 kilogram person and the fluid breakdown of those. So those are the ones that you should try to learn and remember. But looking at these options here, now, D, it's one of those things that you probably will come across when you're studying for perioperative care type questions, or as a little bit in critical care too. But no, within your crystalloids, dextrose, and colloids, dextrose, you barely keep anything in your intravascular space. For saline, about 25% is a good ballpark to remember of the volume that you give will stay in the intravascular space. So if you give a liter, you'll have about 250 mils. So 500 mils is a bit too high. That's half of the volume that will stay, but it won't. Colloids, on the other hand, it's a lot higher because you have those synthetic proteins that have high osmolality. And so a lot more, it'll be the highest number in terms of percentage of its fluid staying. So in E, colloids have the approximate same composition and osmolality of plasma. Well, it doesn't, because it's much higher, its osmolality, because of those synthetic proteins. Okay. Something like Hartmann's or Ringer's lactate will be approximately the same composition, because it's more geared towards being physiologically similar to your intravascular makeup. Average 70 kilogram man will have 11 liters of plasma. Isn't true, because you've only got about actual 3 liters of plasma in the intravascular circulation. So it's just plucking a different number. 11 liters is a total of extracellular fluid. And then B, again, it's one of those things that hopefully you come across a few times in past paper questions or within your revision. And past the MRCS by Raftery is quite good for physiology, I found. And the stomach produces about 2 liters of gastric secretions and fluid, not up to a liter. Okay, so the answer is D for this question. All right, so let's carry on. Another gastric acid themed question, but gastric acid secretion is increased by all of the following except what? And we've kind of been through some of these things, so. Okay, about half, or yeah, just over 60% of you have voted, so I'll give you about 10 more seconds. Okay, let's stop it there. Great, thank you. So the answer for this one is C, secretin. Okay, now hopefully from the previous example questions, you would have known that at least A gastrin, D histamine, and E acetylcholine does in fact increase gastric acid secretion. So it leaves us between B and C, secretin or the short gastric reflex. And it is C, secretin, that it doesn't increase. So mainly, so I mentioned somatostatin. The 3 main hormones that inhibit gastric secretion is secretin, cholecystokinin, and somatostatin. Okay, those are the 3 that don't increase gastric acid secretion. Now, secretin is responsible for producing lots of bicarbonate-rich fluid from the pancreas, rather than gastric acid secretion. And if you think that is its role, producing bicarbonate-rich fluid, which is essentially the complete opposite to acid in the stomach. And so secretin's not going to aid both. If it's bicarbonate, it shouldn't anyway increase gastric acid secretion. Now, B, short gastric reflex. There's a thing called short gastric reflex and long gastric reflex in the gastric phase of acid secretion, and it mounts up to the majority of acid secretion. So the short gastric reflex is refers usually to the local neurohormonal pathways, like your gastrin, like your histamines, like your acetylcholine's within the stomach wall in the parietal cells. That's the short gastric reflex. And then the long gastric reflex is the vagus nerve itself, the long vagus reflex, or the long gastric reflex. That's an interchangeable thing. So yeah, for this question though, it's secretin. All right. So we'll squeeze in, we'll squeeze in another question here. 59-year-old man has been investigated by his GP following lethargy and abdominal pain. He's had blood tests, results in a high calcium level. Which of the following is not true about calcium homeostasis? Sorry. Okay. Yeah, let's end it there. Great. So for this question, majority of you, it was split between C and D. And the answer to this question is C. Parathyroid hormone inhibits osteoblastic and osteoclastic activity. Now, osteoblasts and osteoclasts are essentially do inverse functions. Osteoblasts lay down bone mineral, osteoclasts digest. And so by that nature, it'd be very difficult for a hormone to either promote or inhibit both. And we know that parathyroid hormone has a role in calcium homeostasis as such. And for parathyroid hormone, because it's mainly in a response to low calcium, it will want to increase bone resorption to get calcium into the bloodstream. And so by definition, to do that, it promotes activity of bone resorption, which is osteoclasts. Okay, so it essentially can't be C, and it's not true. It does inhibit osteoblasts, but it activates osteoclasts. Just going through the other options then. Now, as you can see from the, let's go through A. 125 dihydroxycholecalciferol is the activated form of vitamin D, and that increases gut and renal absorption of calcium and phosphate. And we know that because it does so here downstream in the kidneys. We know that. So 25 hydroxycholecalciferol is activated in the liver, but then that goes to the active form of the vitamin D itself, which is 1 to 25, and that happens in the kidneys. And then it's this that aids calcium absorption. It's not in the diagram here, but it does also affect phosphate. So that's true. Parathyroid hormone causes renal conversion from 25 to 125, which is clearly true again here. And it's done by 1-alpha hydroxylase. So that's true. E, PTH causes increased tubular reabsorption of calcium, but decreased reabsorption of phosphate. So in the kidneys, now remember not to get confused between the effects of vitamin D and parathyroid hormone at different stages. But parathyroid hormone itself, it does increase directly absorption of calcium in the kidneys, but because parathyroid hormone increases osteoclast activity, which is breaking down bone, that releases calcium and phosphate into the bloodstream. And so because you only want increasing calcium in the bloodstream, it doesn't reabsorb phosphate in the kidneys to try to maintain that balance, so you don't get hyperphosphatemia. And then D is a tricky one, really, because calcitonin is part of calcium homeostasis, but doesn't actually play a major role. And this is something that I probably always, it tripped me up, because I would read, oh, calcitonin is not essential in, and I would think, no, it is part of it. So I would maybe hastily choose that as an option. But if you look at vast majority of calcium homeostasis, it will just show you parathyroid hormone, and calcitonin doesn't have a significant impact in it can aid, but it's not an essential part of it. And I think that's why, maybe, we don't know, but question writers will include this type of things to try to trip people up. So calcitonin is secreted by parafollicular cells in the thyroid gland, and it's in response to hypercalcemia, and it obviously inhibits reabsorption of calcium and phosphate, so it inhibits osteoclasts. But its effect isn't as dramatic, as significant or quick as parathyroid hormone does. But again, appreciate that that's not. It can be quite ambiguous, that one, and I guess that's also a difficult part of MCQs. But yeah, but see, if you know the physiology and the pathways of what it actually does, it can't inhibit both osteoblasts and osteoclasts. Okay, so in the interest of time, I think we'll end it there for now, and we'll carry this on Thursday evening. So part 2 of physiology will be on Thursday, and I think as part of that, I'll add in a little bit of perioperative care as well. Okay, so again, I hope you guys found that useful. Let me just go over to this. So yeah, the next session is Thursday the 14th, again, same time at 7 p.m. This is the QR code. So your feedback, for those of you who have been tuning in frequently for the sessions, your feedback is really useful. We've been trying to, tailor different things to some of the things that you've said. So again, please fill out the feedback. There's also a link to it on the chat if your QR code doesn't work. Nah, I've just had a look on the Q&A. So there's a couple of questions, both similar. First one, how is the best way to study for MRCS aside from these lectures? Honestly, the most useful thing that I went through were the question banks. I spent a bit of time, maybe about 2 months out from the exam, kind of going through some theory revision, trying to study anatomy or reading through subspecialties. But really, I just worked off the questions. So I went through both EMRCS and PASS test twice. The first time I went through both, I revised around the questions that I did in more detail. So it did take me quite a long time to go through the questions back first time round, especially as there was a huge amount of questions on them. But, it was the best way that I found. It consolidated what you were learning around it. And then when I went over it a second time, it was a lot quicker, and it felt like, I was just basically consolidating what I had learned around. I mentioned last time, in terms of textbooks, I did get some. So those 2 big, thick PASS test textbooks, a friend kindly, gave them to me to use while I was studying, but to be honest with you, I didn't find them all that helpful. I used them for kind of your smaller sections like perioperative care, these type of things, and it is quite good for critical care too, but yeah, I didn't use them a lot. The only test book that I did use quite a lot was Raftery, past the MRCS, mainly for the physiology. And then in terms of anatomy, I learned mainly off the internet and question banks. So as I did question banks, I would answer that question and then learn the anatomy that the question asked about using Teach Me Anatomy is amazing. It's honestly such a good resource, and it breaks it down in real simple terms. The second question, again, is very similar. Best resources to revise for MRCS and good techniques on how to use these. I guess I've just kind of spoken about those. So yeah, really, I think ideally in the last maybe 3 weeks, 2.5 weeks at a stretch, but if you can 3 weeks, I would really be drilling questions. That's all I did. And then in terms of revision, it took, I studied probably 3 months in terms of, properly dedicated studying. And I would say the last month and a half was what was properly intense studying, give or take. It depends what job you guys are working, I guess, because that makes a huge difference compared to medical school. Luckily, I had a GP job, which obviously gave me a lot of spare time. But don't worry if you don't, the benefit of doing past test and using that is you can get the app for it. And so I would just download 200 questions on a part of anatomy and drill it, even though the same sort of questions come up again and again and again. It's just good to consolidate it. But yeah, I did 3 months. It took me about maybe a good month and a half, to be fair, to finish both question banks whilst reading around all the topics. And then the last month and a half was just mainly drilling all the questions over and again. And how did you manage to study for it during FY1? Yeah, I got lucky. I did it. I did it during GP. Like I said, I got very fortunate. And also it was a time when exams, because of COVID, were kind of getting postponed. So I guess in a way, sometimes I started revising and then the exam got cancelled. So I only got like 2 weeks down the line and I just stopped. But when I did properly start, it was about a month into my GP placement, and then I had 3 months on GP. I took a mixture of annual leave and study leave, for which you get, depending on your deanery, hopefully they will give you 5 days of study leave. So that's a week off. And then I used my annual leave. So I had 2 weeks solidly off before the exam, and that was really helpful for me as well. Let me just check. Yeah, so the EMRCS unfortunately doesn't have an app, and I know that you can just go on the actual website itself on the phone. I didn't use it. I didn't find it too helpful to do it on the move, because I'm sure you'll find that a lot of the EMRCS questions are a lot more detailed or more wordy and in depth, and it's less useful to do on the move, where you just want to kind of drill questions, almost like I guess flashcards. So I used past test, and I did it mainly for anatomy and physiology. I used, when I was on, if I was commuting or if I just had a spare hour or two in the day or over lunchtime, I would just get the app up, put up about 50 questions to go through, and I would just do it like flashcards, drilling the same stuff, because, especially because the volume and breadth is so much that you guys are studying, and obviously when I was studying for it, it's not like MRCP where they split it down into part A, B, and C. You're essentially learning all the theory for the whole of surgery in one go. So it is really tough. And, you know, that's why you want to be giving quite a generous amount of time to prepare for it, because, it, you know, compared to when I did part B, part A was infinitely harder. And I'm sure you guys are aware of, you know, just from looking at the pass marks or pass rate, it is a harder exam than part B. So give yourself a good amount of time. I'm sure you all have started. The fact that you're tuning into this puts you in good stead anyway, because it shows that you're probably, you know, being really prepared. You're putting in your work and your time. But if you can get through those question banks twice over, know it in detail, where you've gone through kind of, especially core anatomy and physiology topics. When we come on to specialty-based questions, we can go through the tips and tricks for those type of things. But for anatomy and physiology, it is unfortunately one of those things. You need to know it or you don't. It's harder to give good estimated guesses in those types of questions. So make sure you know those well. I think we've covered most of the questions. So thank you again for tuning in. Oh, there's just one more question in the chat. What textbooks? So I used, like I said, the Raftery textbook. It's called Past the MRCS Raftery textbook. And I used that for physiology. It seemed the most in line. And a lot of people prior to me also recommended that book too. So that's definitely worth, I think, either trying to find a PDF somewhere of it, or sorry, not Past the MRCS. It's the Basic Science for the MRCS by Raftery, Andrew T. Raftery. So that's the one I use for physiology. I mentioned when I was doing the anatomy lectures that because of the lack of diagrams and pictures in this textbook, it wasn't the most user-friendly for anatomy revision, but it was excellent for physiology. And yeah, I use more online resources like Teach Me Anatomy for that side of things. Okay, and then the only other two textbooks I did have access to but didn't really use again were the two past test textbooks. But when we come on to kind of, you know, the specialty based ones, like I said, we'll give you the tips and tricks when we get onto it. Okay. Yes, I went through both question banks twice each. So I did past the MRCS, I mean EMRCS, and then I did them twice over. And also, just to, I don't know, you know, if you were worried about how your pass marks are as you were progressing through these types of things, you know, especially on EMRCS, I was, you know, my average score that they measure, or you can see, it was not like, you know, I wasn't getting anywhere near 70%. As long as you, when you go through it first time around, as long as you take the time to try to digest either the justifications for the answers that they give you, just take your time in understanding the questions first time around, and then the second time you can literally just sift through them, you know, and drill the questions, and it's a lot quicker when you go through it the second time. Aside from anatomy and physiology, my current understanding is go through each exam domain using question banks to guide learning once then twice. Yeah, that's essentially what I did. I thought, you know, I tried a few things right at the beginning where I sat down with a textbook and just tried to go through topics, but, you know, I found that method really difficult. So I used the questions because it's more engaging, isn't it? Even if you're getting it wrong, it doesn't matter when you're going through it the first time round, as long as you digest the answer, justification of why things are correct or not, and then go on from that. And then as I was going through it, I would make a list just of topics that will come up often that I was getting wrong consistently. So, and then I would have maybe a list, one A4 list of one A4 document that I had some topics that I would keep getting wrong, you know, even though I would study it, the question might come up a week later and I'd still get it wrong or something like that. So I made those type of things there. And then in the last maybe 2 days, I just went through those topics that I thought were really lacking in when I was studying. And they were just really random things. Some, you know, for whatever reason, it just took me absolutely ages to kind of learn the forearm muscles and the neurovasculature of the arm. For some, you know, it took me ages. So it was just something that I had to constantly go over and over and over again. So yeah, everyone will have their strengths and weaknesses, but as long as you put in the time, and obviously make sure you're giving yourselves good breaks and rest well, because while you're trying to study, while you're working is really challenging. So pace yourselves as well. Okay, so I think that's it. Again, thank you guys for tuning in. The next session will be Thursday evening. Hopefully it will be useful again. And then otherwise, I think we'll end it there.